Continuing production of The Open Mind has been made possible by grants from the Rosalind P. Walter Foundation, the Bluestein Family Foundation, the Joan Ganz Cooney and Peter G. Peterson Fund, the Malkin Fund, the May and Samuel Rudin Family Foundation, the JoAnn and Kenneth Wellner Foundation, the John D. and Catherine T. MacArthur Foundation, and from the corporate community, Mutual of America. I'm Richard Heffner, your host on The Open Mind, and this is the first of two programs on reality-based health care for Americans that we record early in October 2009, even as health care reform measures continued to wend their way through the Congress with what many fear as considerably less than all deliberate speed. Indeed, one wonders what it is about us, about our political system, about our ultimate concern, or lack of it, for the public interest that finds America still facing a higher cost of health care than anywhere else in the world, with U.S. health care at more than twice the per-person cost in other major industrialized countries, and still with scores of millions of Americans uninsured or underinsured. In a congressional presentation just a week ago, today's Open Mind guest, marshaling facts and figures, as she always does, dramatically pointed out that failure to act in this crucial area has had severe long-term consequences. On the three major occasions in the last 50 years, Presidents Nixon, Carter, and Clinton all proposed comprehensive health reform, she testified. And had they succeeded, by now, the savings to government budgets, to employers, and to households, we ourselves, would have been in the trillions and trillions of dollars. Presumably, too, value added to our personal and collective health would have been immeasurable. Now, my guest, of course, isn't new to facts and figures relating to reality-based health care matters. President of the Commonwealth Fund, a major philanthropy engaged in research on health and social issues, Dr. Karen Davis is a distinguished economist with a long career in public policy research, having served earlier as chair of the Health Policy Department at the Johns Hopkins School of Public Health and as Deputy Assistant Secretary in the United States Department of Health and Human Services. Now, Dr. Davis first joined me here a decade ago, setting forth then what she called a 2020 vision for health care, a plan I dare say now, almost at the 2010 midpoint, remains quite similar to what she recently called for in Washington as forging a health reform consensus. And Karen, I wonder whether this notion of consensus is going to carry us through now.
I think at the core there is a lot of consensus. Obviously, we focus on the differences as bills work their way through Congress. But when you really look at what's under consideration, everybody agrees we can't continue on our current course, and that health insurance needs to be affordable for families. When the average family premium is $13,000 a year, even moderate income families can't afford to pay that without help from their employer or some kind of premium assistance from the government.
So your assumption is that a common approach is going to result in something in the next few months?
Absolutely. I think we see that in the proposals. At the heart, there is a commitment to three goals. Making coverage affordable for those who now have it, to make sure they don't lose it and that it really helps them pay their bills and get the care they need. Secondly, closing the gaps in insurance coverage with almost 50 million people uninsured, making sure that they have coverage and good choices available. And third, slowing the growth in healthcare costs. As you say, we spend twice what other countries spend on healthcare, and healthcare is consuming a greater and greater proportion of our economic resources. So there's agreement on the goals, and I think there's also agreement on the basic approach, the basic strategy.
I don't want us to go on today saying everything is great, because that isn't true, is it?
Well, there are obstacles, otherwise it wouldn't be going through this intense democratic process of deliberation. Certainly there are concerns from those in the industry that their revenues will be affected. So insurance companies are concerned about new choices that would increase competitive pressure on them to really yield real value added to the healthcare market to slow the growth in costs. There's concern, legitimate concern on the part of hospitals and doctors that maybe they won't have the same amount of money they have currently. But I think the basic truth is that as we cover more people, it'll eliminate bad debts and charity care that now exist in the system, and they can achieve certain improvements in productivity and eliminate a lot of waste that's in the healthcare system to slow the trend in healthcare costs. So there's concern, but I think they can be addressed.
Well, I gather from reading what you've been writing for all these many years that affordable coverage for all is your principal point, getting people into health insurance plans. And I was fascinated that as recently as yesterday, turning to my computer and getting another of the Commonwealth Fund's e-alerts, you write here about improving care and reducing costs by expanding coverage. And it isn't just a matter of the cost of bringing so many more millions into our health plans, but rather the savings that are involved. Would you explain that to me?
Well, we have a very fragmented, complex system. People are changing coverage all the time, and we pay a lot in the form of just administrative costs. In fact, we spend more than any other country as a proportion of our health spending just on insurance administration. If we spent what the lowest three countries spend, we could save $90 billion a year. And I think everybody would agree that that's waste. But our surveys of the population show they're often getting duplicative care. About 20% of the public says there's been a time when they've had a test repeated because the doctors couldn't find the records or they just wanted to do their own tests. So we could eliminate that kind of duplication. We find that there's a gap in care coordination. One doctor doesn't know what the other doctor knows. So we don't have a modern information system that helps us make sure the records are available when they're needed, and we don't have costly administrative costs of filing records, retrieving records, and we don't repeat care, unnecessarily tests and other types of procedures.
Now, do you see these problems as being cared for to any considerable degree by the legislation that is now being considered?
Absolutely. I think what's being considered will take us a long way toward the path to a high-performance health system. Congress already started with the economic stimulus bill called the American Recovery and Reinvestment Act, and it put substantial funds into helping doctors and hospitals adopt modern health information technology systems, so that will help. In addition, they funded, to the tune of $1.1 billion, research on the scientific evidence of what really works, which drugs are better than others, which treatments are better than others. So that's an important first step that's laying the foundation for health reform. But the proposals themselves would build on that foundation and start to change the way we pay doctors and hospitals to reward them for doing the right thing and getting the best results. Right now, we reward them for lots of procedures, lots of services. So every time you show up at the emergency room, they get more money. Every time you get readmitted to the hospital, they get more money. Every time they see you do a test, do a procedure, they get more money. What the bills before the Congress would do is to move to what are called bundled methods of payment. But what that really means is a global fee for the treatment of, say, a hip fracture or a coronary bypass operation. It's almost like care with a warranty. You get paid once, and that covers everything that you need. And so there's an incentive then for the hospital and the doctor to avoid complications, make sure people don't have to come back and have the surgery again or come back to the hospital for a complication following treatment. So it would fundamentally change the way we send out incentives in the healthcare system.
Well, I was just going to say it's such a fundamental change. Is that really provided for in the bills that now stand the greatest chance of coming through and ending up on the president's desk?
I would say it lays the foundation. Both the House and Senate call for creating a Center on Payment Innovation within the Medicare program, and it would test these new methods of paying doctors for being what's called a medical home or a health home. Which means the doctor gets paid more if he keeps your diabetes and your asthma and your congestive heart failure under control. And it would test these new methods of paying a global fee for certain surgical procedures, including not just the surgery, but the anesthesiologist bill, the radiologist bill, and any follow-up care you need for, say 30 days. And it would also promote the growth of what are called accountable care organizations. But those are, say, large physician group practices or integrated delivery systems that also have a hospital. And they would get a fixed amount and share in the savings if they slow the growth in cost. But the main thing is they would be accountable for the results of the patient, making sure the patient gets the best care, has the best outcomes, has the best chance of enjoying high quality of life.
You know, when that has been written about, and I've read it and heard it, I've had an uneasy feeling of how I would react to that had I been smart enough to become a doctor. Now, how are the doctors reacting to this?
I think for the primary care physicians, your internists, pediatricians, family physicians, this is practicing medicine the way they'd like to practice medicine. So rather than being worried about bills, and I get paid if I see you, but I don't get paid if I talk to you on the phone. I don't get paid if I send you an email. I don't get paid as much if I have all my patients come in and meet with an educator about how to control their diabetes. In fact, they would get a certain amount every month for every diabetic patient in their practice, every patient with asthma, every patient with high blood pressure. And they would get bonuses on top of that if those conditions are controlled and if patients are getting early cancer screening and all the preventive services that they could receive. So it would shift the whole focus away from I need to have you come in and see you, I need to do these tests, otherwise I don't generate enough revenue for my practice, to say I'm getting paid a reasonable amount for the primary care of my patients, and I can provide that in a way that works for patients. Busy patients may prefer to do a certain amount on the phone or by email. Others need to come in and they need to spend a lot of time with me, but I can afford to do that because I've been changed and changed the way that I get paid, and I get paid for providing good care. And I think a lot of primary care physicians welcome that.
You say primary care physicians. Do you think this will redirect the flow of medical students from specialization back to the general practice that we knew in the past?
I absolutely think we have to do that. Right now, the compensation levels are 2 to 3 times higher for specialists than they are for family physicians or pediatricians or internists. And it's not surprising that more and more doctors now are deciding I'd rather be a dermatologist. I'd have regular hours and I'd have more take-home pay. So I'd rather do that. So we need to change the compensation. But it's more than that. It's changing the style of practice. Many physicians today can't really be on call 24/7. They need to be part of a larger system that has coverage on nights and weekends. Urgent care centers or retail clinics are part of the system, and they share medical records.
Is this the pattern in other large countries, other large industrialized countries around the world? Is this the pattern that's generally followed?
Absolutely. Other countries, particularly the Netherlands, Denmark, have good systems of off-hours care So you can call in the evening. You immediately get a doctor on the phone in Denmark, and they can listen to your problem, decide to prescribe a medication, and you can pick it up at your pharmacy. And then they'll email your doctor and tell your doctor what care you got on the welfare service. In the Netherlands, they use a lot of nurses to do triage in the evening, and they've got a system where you can get care very easily. This shows up on Commonwealth Fund surveys of people in different countries, where in the U.S., people are much more likely to say they have difficulty getting care on nights and weekends. They're more likely to go to the emergency room, even for things they said their own doctor could have taken care of, but they just couldn't get an appointment, couldn't get in quickly to see their own doctor.
Now, what about the specialists? What are we finding in the halls of Congress now? Are the specialists, are the physicians who have moved from the family practice, from the basic practice of medicine to the higher paying specialties, are they presenting problems in getting the kind of bill you want through the Congress?
Well, I think it differs from one specialty to another. It does mean a different style of practice. It does mean a team approach to care. And if you've been used to being an entrepreneur, solo practice, doing things your own way, you're going to have to change and join together with other physicians into what are called accountable care organizations to be accountable for all the care, not just your narrow piece, but the total care of the patient, so that there's really a system and that care is coordinated. So you're not just the surgeon knowing one thing, but the doctor taking care of the patient after they go home, not having that information. They've got to share that information and work together for the best of the patient.
Now, there was another point about all of this that I wanted to ask you about in this e-alert that I received yesterday from the Commonwealth Fund. The matter of improving care and reducing costs by expanding coverage. Your researchers were reporting that those who are covered, those Americans who are covered adequately, actually cost society much less after they reach 65 than those who have been uninsured or have too little insurance, because those who have been insured have been doing the things that you need to do to be healthy, to remain healthy, to become healthy. And that as a nation, we will be more than rebalancing the cost of adding millions to the insured ranks.
Absolutely. A team of researchers at the Harvard Medical School, with support from the Commonwealth Fund, has found that there are real consequences of older adults being without health insurance coverage. And then by the time they turn age 65 and qualify for Medicare, they have real problems that increase the cost to the Medicare program. And that's not surprising. As adults get into their 50s, into their 60s, they're much more likely to start experiencing things like high blood pressure, to have high cholesterol, to have various kinds of health problems that need to be attended to. One needs to prevent diabetes, one needs to control that hypertension, that high blood pressure, so people don't have strokes, don't have complications of diabetes that can include, for example, kidney failure, or even having a leg amputated if they're not followed closely. So there's a price to pay by having uninsured adults at any age, but particularly among older adults that are prone to have many of these chronic conditions. So it does save money to the Medicare program to make sure that people have been getting proper care in the period of time, the decade or so before they enter the Medicare program.
In the scare tactics that have been used by the opponents of the present drive for reforming medical care in America, there has been so much written and said about death panels and about the degree to which Medicare will be disadvantaged, that there'll be less money for the elderly. Is there a response to that that's rational and reasonable and hopeful?
Well, I think people have come to understand that those death panels were never part of the legislation. There was a provision that would pay a doctor for counseling patients about end-of-life options. Right now, they're expected to do it, but they aren't paid for doing it. So it would have paid them for doing that. But there were never death panels, and there were never going to be limits on care that would prevent people from enjoying quality of life at the end of life. The second issue has been that some of the savings that are used to offset the cost of covering the uninsured come from slowing the growth in Medicare outlays. So obviously beneficiaries are concerned that that's coming out of their benefits.
Is it?
But truthfully, what the American Hospital Association, the other hospital associations have said, is that they can eliminate some waste and they can achieve improvements in productivity, and they can slow the rate of growth in what they're paid by 1 percentage point a year. Right now, these outlays are expected to go up 6.5% a year. They said they can hold it to 5.5%. % a year, and they agreed to knock 1% off of their raise every year, if you want to call it that. And so instead of getting a 6.5% raise, they would get a 5.5% raise.
But not at cost to the patient.
But not at a cost to a patient. That's
in care as well as funds?
That's simply by improving productivity. And I think most industries would like a guaranteed 5.5% increase. And I think most American workers would like a 5.5% guaranteed wage increase every year. So I think it's reasonable to slow down what has been an extraordinarily rapid rate of growth in healthcare costs, and to really insist on taking a look at operations and see if you can't trim 1% of waste out of the system. And certainly with modern information technology, with research on what is effective, what works, I think hospitals can do that. The final issue has to do with a part of Medicare that makes choice of private managed care plans available to Medicare beneficiaries. That started back in the early 1980s, and there were many good systems of care that did enroll patients in these what are called health maintenance organizations during their working lifetime, and then they qualified for Medicare. So the basic idea back then, when it started, is that they should be paid a percent of what these patients would cost the Medicare program, say 92% of overall costs. But right now we pay 113%.
How did that come about?
Well, this was part of the Medicare Prescription Drug Act in 2003. People didn't focus on that provision, but it was a time when people said we need more private coverage, and they can do it more efficiently. So we ought to encourage them to enter the Medicare program, and the way to encourage them is to pay them more than people would otherwise cost the Medicare program. They will give some extra benefits to people who enroll, and now about 10 million out of 44 million Medicare beneficiaries enroll in these private plans, but they are overpaid. So you get better benefits if you enroll in them than if you enroll in the regular Medicare program. And so what this most of the proposals before Congress would do was say there's really no justification for paying private insurance companies more money than it would otherwise cost us to take care of these patients, and they would trim those payments.
But then, in all honesty, we have to say there are going to be a lot of people who will be hurt.
I don't think they'll be hurt. I think they're the 10 million people who enroll in private managed care plans under the Medicare program aren't going to get quite the supplementation they're getting. But those plans are also making high profits, so they can absorb some of that by just taking a little less administrative overhead.
Will they?
I think we should insist that they do. And some of the bills do set what are called minimum medical loss ratios. That means the percent of the bill, the percent of the premium that really ought to go for medical care. Nationwide, for many of the large companies, they keep 17% of the premium in either administrative costs or on profits. And in other countries, that's 5%. So I think we're learning that there is room to reduce some of that excess cost or even excess profit and to absorb some of these economies. To really have the kind of health system we need in the U.S., with everyone having affordable coverage, everybody's going to have to do their part. They're going to have to share responsibility. And that means the uninsured themselves are going to have to contribute. Employers are going to have to contribute. But we're going to have to identify in the federal budget money that is either being wasted, excess payments to private insurance companies, or excess benefits for a few that happen to have a particular niche in the market.
There seem to be, when you say excess benefits to some individuals and to a number of business organizations.
Well, what these plans would do is define for the first time an essential benefit package. So what should be covered? And what proportion of the bills should be picked up. Right now, there are no standards on private insurance plans. So you buy something, you think it's going to be there when you need it, and then the bills come in, and you find out, much to your horror, that they aren't covered. And certainly our surveys show that 72 million people have problems paying medical bills. They have accumulated medical debt, and 60% of those were insured at the time that they incurred those expenses. So having a defined essential benefit package will be a very important component of this overall reform.
In the minute and a half we have left to this program, then we'll pick up on the next, but I wanted to ask you, what's the major source of opposition to health care reform?
I think there's a lot of support. Actually, the doctors and the hospitals and even the pharmaceutical industry are supporting reform. It has caused discomfort to the private insurance industry. Business is worried about what they would have to pay. And obviously, there's a concern about the federal budget and will it really, as the president says, not add a dime to the deficit.
What do you think?
I think it is doable. I think there's a very practical approach now being considered that builds on what works, fix what doesn't work, and finds a reasonable way to have everybody contribute something to really make it affordable for everyone.
Dr. Karen Davis, thank you so much for joining me today on The Open Mind, and stay where you are so we can go on with this discussion. And thanks, of course, to you in the audience. I hope that you join us next time as well. Meanwhile, as an old friend used to say, good night and good luck. Open Mind website at theopenmind.tv. Continuing production of The Open Mind has been made possible by grants from the Rosalind P. Walter Foundation, the Bluestein Family Foundation, the Joan Ganz Cooney and Peter G. Peterson Fund, the Malkin Fund, the May and Samuel Rudin Family Foundation, the JoAnn and Kenneth Wellner Foundation, the John D. and Catherine T. MacArthur Foundation, and from the corporate community, Mutual of America.